Eliza. Thanks, organizing committee. I'm really happy to have the opportunity to share with you some background about graft versus host disease. And I think the presentation will be about 20 minutes because I would like to give the floor to you guys, to the audience, to have some concerns, questions about GvHD and treatment options, etc. So I would like to try to make it a little bit interactive, if possible. So graft versus host disease is one of the major limitations of bone marrow transplantation. And it's a life-threatening complication. And although the treatments and prevention have improved over the last couple of decades, it continues to be a significant limitation. And if you end up with chronic form of graft versus host disease, it's also definitely quality of life, let's say, impacting. So there is earlier detection with biomarkers, there's new treatments, but as mentioned, it continues to be a serious concern. And as mentioned earlier, I would like to keep enough time for the audience to ask me some questions and to have some conversation with you. First, some numbers. And I'm showing you one manuscript, but the incidence of graft versus host in the various publications is about the same. So this is a manuscript from a couple of years ago. This is not only ALD, but also GLD and MLD. And we all know that if you go into transplants pre-symptomatic, you're doing better. So that's the figure on the left-hand side. So these are survival curves on the y-axis, 100%. And you see that it ends up to around 80% if you are pre-symptomatic, and when you are symptomatic, the survival is less. So this is survival, but what about the graft versus host in this analysis? And we included 160 patients in this analysis. The incidence of graft versus host, grade 2 to 4, and I will explain a little bit more later, is 1 in 3. So 35% of the patients will develop a grade 2 to 3, grade 2 to 4 graft versus host disease. And this is the acute form. The grade 3 to 4 is 20%, and that's significant because this is considered moderate to severe. So that can be a very bumpy time with a lot of hospital admissions, but when it continues to be acute form and when you are cured, you're okay after. But the acute form can result in a chronic form. And as you can appreciate here on the left-hand side, the chronic GvHD rate in this analysis was 30%. So that's also significant, with 10% extensive. And mainly extensive is quality of life impacting because it requires systemic immune suppression with prednisone and some other immune suppressive agents. And a predictor for increased acute graft versus host disease was the interval between diagnosis and transplant. So if the diagnosis, the interval was longer, the graft versus host risk was higher. And when the interval was shorter, the graft versus host disease incidence was lower. So what is graft versus host disease? So I will bring you back in the late 50s and 60s when the first transplants were done. Actually, the first successful bone marrow transplant was done in 68. And it was recognized as a disease in the mid-60s because there were already, let's say, attempts before. And the first grading or the first criteria for graft versus host were defined in 1966. Of course, that has evolved over the last couple of decades because we were more successful in the 70s and 80s and later. And now there's an NIH consensus classification already, let's say, published about 8 years ago. 9 years ago. So we have the acute form, that's the classical acute form. We have a late acute form, and then you can see after 100 days, you see that the incidence of chronic GvHD also, let's say, goes up. And then there is an overlap chronic form. So it's more sophisticated grading from acute and chronic historically to acute, late acute, chronic overlap, classic, chronic. The acute form classically also mainly involves skin, GI symptoms, and liver. And the chronic form is can actually affect all the organs, including eyes and mouth and lungs, etc. Musculoskeletal. So it's a more sophisticated grading of acute GvHD and chronic GvHD. So from grading to risk factors. So HLA matching, every family who has undergone a transplant knows that HLA matching is important. If you have a fully matched donor, the risks are lower. And nowadays, we can do better matching. So if you have a fully matched donor, the risks are lower. Other donor factors that are influencing is gender, CMV status, so that's a virus. Also age, and I will show you on the next slide. And then there are some genetic variations that also may make you higher risk or lower risk. Also, host factors can influence. That's again, that's age and that's inflammation. So what are risk factors considering the graft and the chemotherapy? If you get a reduced intensity conditioning regimen, and this is general, so this is not only focusing on ALD, because we don't give TBI in ALD and leukodystrophies, but if you get a TBI with higher dose of the TBI, that's the, let's say, irradiation, you have more chances on GvHD because you will give more damage to the body, which may initiate trigger GvHD. If your conditioning regimen is reduced intensity, you have less acute GvHD, but you have higher chronic GvHD. Reduced intensity, we don't see that frequent in transplants for metabolic diseases, but we see it more frequent in malignancies. The graft is important. So if you use a cord blood graft versus a bone marrow or a blood graft, you can allow more mismatches in cord blood versus bone marrow versus blood. And if you do T-cell depletion, which is usually not done in transplant for metabolic diseases, you also see less acute GvHD. But if you do T-cell depletion in metabolic diseases, the risk on graft failure are higher. So it's always a balancing act. And the cell dose is important, in particularly if you give high cell doses in blood transplants, your risk on GvHD is also higher. So risks are the matching, the donor specific variables, but also the conditioning regimen and the donor source. So this is an example. This is for acute leukemia, and you can appreciate on this slide on the y-axis the percentage of patients who are developing GvHD by age group. So less than 5 to 20 on the x-axis, and more than 20. And you can appreciate the higher the age, the more risk on graft versus host disease. So how can we prevent graft versus host disease? So of course we can select the best donor, better matched donor, have CMV matched donors, go for a male donor instead of a female donor, and we can give prophylaxis with drugs, and those who have undergone a transplant or having a family member who have undergone a transplant. The agents used are cyclosporin, methotrexate, MMF, and prednisone, also tacrolimus or sirolimus. So there are drugs given after transplant, immune suppression, in an attempt to reduce the risk of graft versus host disease. But even with these drugs, you can still develop graft versus host disease. So how do these drugs work? I will skip this. So this is on a more cellular level where the various agents and molecular level where the various agents work. Um, they have they work at different places. And how successful were we over the last decades to prevent graft versus host disease? With these drugs, with these classical drugs like cyclosporine, tacrolimus, methotrexate, MMF, and actually it's a little bit disappointing going back to the late 80s, 90s, and also over the last 2 decades in the 2000s, the incidence of graft versus host continues to be pretty similar, despite new regimens. So when we are talking about transplants and metabolic diseases, the risk, depending on cell source, ranges between 20, 25, and 35% grade 2 to 4 GvHD, with grade 3 and 4 to be the moderate to severe graft versus host disease risks. So other agents to prevent graft versus host disease is ATG or ChemPad. And what we have learned over the last couple of years, that ATG, that's an antibody giving in the conditioning regimen, can prevent graft versus host disease. But we also have learned over the last couple of decades that there is a delicate balance. So if you give too much GvHD, yes, you are successful in preventing GvHD, but you also impact the immune reconstitution after transplant, which can give rise to more infections. And that can result in a higher transplant-related mortality. More recent, we have learned how to better individualize the ATG, and that has resulted in better immune reconstitution, but prevention of graft versus host disease, and with better survival chances. So those who underwent a transplant, most of the patients who underwent a transplant for metabolic diseases also got ATG in their conditioning regimen. A more recent development, or relatively new, although it's already used for 10, 15 years, is post-transplant cyclophosphamide, mainly used in the adult world, but also now more frequently in pediatrics. In transplant for metabolic diseases, we don't see it that frequent, although in some low-income countries, it is used more frequently because it's cheap and it's simple, and it's given 3-4 days to 5 days after infusion of the cells. So you infuse the cells, you give the high dose chemo after transplant, mainly to deplete, to kill the cells that proliferate in the early phase after transplant. Because the hypothesis is, and this is also shown in the lab, that when you give the cyclophosphamide between day 3 and day 5 after transplant, you will mainly kill the lymphocytes, the cells that give GvHD, that are, let's say, proliferating very fast. So that's the bad guys. So you mainly deplete and get rid of your bad guys that are infused at day 0. And actually, it's pretty successful. On the figures, on the cumulative incidence figures below, on the y-axis against the percentage of GvHD, and you can see that, and this is leukemia, but you can appreciate that the acute GvHD is only 27% and grade 3 to 4, so the more severe forms is only 5%. And on the right-hand side, it's the chronic GvHD. So again, this is not used frequent after transplant, and cyclophosphamide is also a toxic agent. But this is just to give an overview on what kind of agents are used. Recently, a randomized controlled trial, and this is leukemia, where they have compared various regimens to prevent graft versus host was concluded, and that will be presented in an upcoming BMT meeting. So the diagnosis and treatment, I will try to go over that in 5-6 minutes, so we have some time to discuss. So acute GvHD, I mentioned the most frequently involved organs are skin, GI, and liver. And skin is usually, if you develop GvHD, is involved, it is usually involved in 80% of the case. So if you developed it in 80% of the cases, it's the skin is involved. And we can do a biopsy on the right-hand side. I'm not going to explain these histology figures. But if you have skin only and it's less than 50% of the skin, you usually are only treated with, let's say, topical steroids. When it gets more than 50% and when the gut gets involved or the liver gets involved, you need to get systemic steroids. And then it becomes an overall grade 2, 3, or 4. And these here are some pictures and how it can look like, and be, let's say, pretty intense and pretty severe. And here another picture where mainly the foot soles are involved and the legs. And it can be pretty painful. And when the skin is involved, plus the gut is involved, I'm showing you here, then you need to get treated with systemic steroids. Again, here we can do biopsies, and on the right-hand side, it's such a biopsy. So this is for the pathologist. I'm not going to explain you this figure, but when the gut gets involved, the outcomes gets worse. And in particularly, I'm skipping this slide here. In particular, when you're not responding to the first line of treatments, which is prednisone/steroids. The liver can also be involved in the acute form, although it's rare, in particularly in the younger age, but it can occur. And you can also have isolated liver, but that's ultra rare. So what you see mostly and most of the times is that skin plus gut is involved, and sometimes the liver as well. I already told you about the NIH consensus meeting. So we are pretty harmonized in grading the graft versus host disease. And this is important because then you can compare between various centers. So all the centers register their data to the CIBMTR. Actually, it's a federal mandate here in the US, but also in the European Union. You have to report some minimal data, and that includes graft versus host disease because it's the most important limiting complication after transplant. And if you develop, and this is survival and grading, so over the years we had different gradings, but the CIBMTR grading is the most frequently used grading system now. That's in the middle, that's the red box. And on the right-hand side, you can appreciate the survival chances if you develop grade 1, 2, 3, or 4. And you can see the curves going down when you develop grade 3 or 4. And when you are grades 1 or 2 or 0, the survival is approximately the same. So in figure A, you see the curves going down. So that's the figure of survival. And in the B figure, where you see the curves going up, that's the non-relapse mortality. So that means mortality related to the procedure. More recently, we also have learned, and this is from my lab, if you develop GvHD, but you are immune reconstituted, and this is not neutrophils, but this is lymphocytes, and in particular CD4s. Even when you develop a grade 3 or 4 GvHD, if you develop graft versus host in the context of sufficient immune reconstitution, your outcomes are still pretty okay. Yes, you have a bumpy time and you are likely have extended hospital stay, but your survival chances are similar to the patients who do not develop graft versus host disease. So immune reconstitution, lymphocyte immune reconstitution is really important after transplant, also to get control over your graft versus host disease. So the first line treatment I already mentioned you is steroids, is prednisone. And the response to steroid therapy is crucial. If you fail to respond within 3 days, your outcomes are worse. If you have no improvement after 7 days, so that's under the section failure. If you do not show improvement after 7 days, your outcomes are also poor. Or when you have an incomplete response after 14 days, we also consider you steroid refractory. And then it depends on whether you have immune reconstitution or not, or what the second line treatment is going to be. But failure to respond to steroids makes the outcomes pretty poor, with a high transplant related mortality. And the right treatment in second line, that's not completely clear. So here the treatments, steroids, first line, second line treatment, there's actually only one FDA approved second line treatment. So that's what we use here at MDF, at let's say MSK. But if that fails, you go to other treatments, and it's mainly anecdotal data. So we have at MSK also third line treatment. So we use either MSCs or let's say ECP. But to get control over your GvHD, it's not zero, but the outcomes get worse and worse. And MSCs, so this is mainly single center arm experience, but it suggests that there is some effect. Also the center I came from in Europe, we used a lot of MSCs. And if you respond, your outcomes are pretty okay. If you do not respond to the mesenchymal stromal cells or stem cells, the outcomes are extremely poor. So back to the messages. A graft versus host disease is a life-threatening complication after BMT. Also, there has been some improvement over the last decades. It's still a limiting factor for BMT. And I would like to end the presentation here and have some questions and answer some questions from the audience. Thank you.
Thank you so much, Dr. Boelens. With that, I know that was a lot of information. We would like to open it up for questions. So again, if you would like to ask something, please go to your toolbar, the reactions, and raise your hand. And we will do our best to address as many questions as possible. Don't have anything yet. I do want to mention we are aware of the question in the chat. A couple people asked about the environmental triggers on a previous presentation. We're going to have Dr. Malak talk a little bit about that after our break, because they'll be discussing the neurology guidelines during that presentation. But again, if there are any questions for Dr. Boelens.
Or if someone would like to, or is having questions later on, I'm also happy to answer the questions by email.
I think someone had a question about male versus female donor. I see that in the chat.
Yeah, so in registry analysis, it was found that that female donors who had pregnancies, because they are exposed to other HLA as well because of the baby, the outcomes were worse. So the preference, if you have unrelated donors and you have the ability to select a male donor, the preference is, so this is mainly based on registry, let's say, analysis. So male donors have a lower incidence of graft versus host disease versus female donors, but mainly because in female donors who had pregnancies before. So if you can avoid that, and of course it's not always an option to avoid it because it's still important. So in the hierarchy, you would like to have the better match because that has more impact than male versus female.
Jill Smith was first in the chat to say that she has a question.
So female and male donor in matched siblings, kids, there's no impact. But if you have adult donors, female donors who are unrelated and who, let's say, carried babies, there is an impact, but not for matched siblings who are 5, 6, 7 years old.
Okay, Jillian Smith has a question. You can go ahead and unmute yourself, Jillian.
It's not letting me. Oh, there we go. Sorry.
Hi.
Hi, how are you?
Good.
Good. My son is 2.5 years out post-transplant. He was a late find with a less score of 10. He did have a 10 out of 10 match, but was female. We've been dealing with stubborn GvH liver. Is the most issue. He does have skin and eyes, but his skin's just vitiligo and dry eyes. We've tried pretty much all the medications and he starts to respond and his LFTs go back up again. But we most recently just finally started IL-2 along being back on prednisone again, which we seem to be having a pretty good response. Do you see good responses with that? I know it's kind of newish for the kids, but have you dealt with that at all?
Yeah, so there are a couple of trials open for low dose IL-2 and so there is let's say definitely data that there is let's say positive effect on that. So we don't have that open, that clinical trial. Is he included in a clinical trial or is he off trial?
He's not. We're in Boston.
Dr. Because it's open there, I think.
Yeah, Dr. Wangbo, I know, did a lot with that. He sees Christy Duncan, but we've only been on it. This is our 4th week on it. He's odd because I mean his LFTs are high, but he's perfectly fine, knock on wood. He does have recently some depletion of bile ducts, but his PTs and INRs are perfect. Everything's functioning perfect. He just doesn't, it's just very, very stubborn. But I know he's one of the few that have been on this. So I just didn't know if you guys had dealt with this yet or not.
No, so, but this is, no, we haven't used it here because the trial's not open and yeah. But what I've read and what I've seen and what I've heard, yes, there is some, let's say, encouraging data. And so it may help that he is still young.
Yeah.
Because you can see some late complete responses in the, let's say, pediatric population, while that's usually not the case in the adult population. Okay. So with a lot of patients, he may be lucky to get control even after years. But yeah.
Okay, we're going to go to one more question in the chat. Can JJ comment on new technology companies like Magenta are developing and how those data look so far, if available?
Again, can you repeat that question about new?
Sure. Can Dr. Boelens comment on new technologies companies like Magenta are developing and how those data look so far, if available?
Okay, so that's not a GvHD related question, or is it a GvHD related question? Because Magenta was having the expanded cord blood protocol, so I'm not aware of GvHD meds.
Is there less GvHD with their protocols?
Oh, is there less GvHD with their protocol? So I haven't seen a recent update. So the series they have, let's say, published or presented at meetings was only 6 patients. So I think the numbers are a little bit too low to, let's say, comment on that. So there was still GvHD in that group, but 6 patients, that's a little low number to give a meaningful, let's say, comment. So I think ultimately, if we can have safe and effective gene therapy, that will prevent the GvHD. But of course, we need to compare the late outcomes and the ALD-related outcomes between the gene therapy and transplant as well. But you can obviously completely prevent GvHD if you do autologous gene transduced transplant, because then you infuse your own stem cells and your own cells, and you cannot get GvHD. Yeah.
Okay, thank you so much, Dr. Boelens.
Okay, pleasure.